consultant urologist here. He graduated from the University of Leicester in UK and have get the membership of the Urological Association in Malaysia in 2016. So consider a senior member of our team and specializes in uro-oncology. So I hand it over to you, Prof. Pang, for the introduction.
Yeah, thank you, Professor Ong and Dr. Ahmad and all our audience online. Thank you for your patience and sorry for a bit of delay. We are very honored to have a joint meeting together with University of Malaya. Started with this urological section first. So I think I will not further delay our speaker talk. I think I would like to introduce our first speaker. On my right is Dr. Yu. Dr. Yu Kaijie is our consultant urologist, and he also the director of our uro-oncology department. He graduated from Chang'an University, and then he got training in our hospital, and he spent 2 years in MD Anderson in America. So I think he's expert in uro-oncology, especially he's very focused on the prostate cancer treatment. So today he would like to share with us about his experience in robotic surgery in treating prostate cancer. So I'll just hand it over to Dr. Yu.
Hello, Professor Ong, Professor Fong, Dr. Lin Ahmed, and Dr. Zhang, and everyone on the webinar. I'm Dr. Yu. It's my great honor and privilege to attend the first joint conference held by University of Malaya and Linko Chang'an Memorial Hospital. I'd like to show my gratitude for the great support from GUA committee so that the broadcast could reach much more readers in our country. And today, I'd like to talk about robotic surgery in locally advanced prostate cancer. Next. And this is the outline today, and I will focus on the trend of robotics in locally advanced disease and the problem we are facing in this era as well, including the timing for adjuvant therapy. And fortunately, we have chance to look into our own data and hope we could have some contribution to solve this problem in real world. Next. Next. And we know that robotic surgery has already become the most cutting-edge advancement in the recent decade. And robotic offers several advantages compared with standard laparoscopy, including the use of a high-resolution camera with three-dimensional visualization, while the robotic arms allow surgeons to perform more precise dissection and potentially leading to better preservation of functional structures and better preoperative outcomes in the end. So here, this is the recent meta-analysis, including 33 studies from major database for analysis. Next. And this is the forest plot demonstrating the advantage of lower blood transfusion rate to robotic surgery. And there are much more plots for comparison. And in conclusion, robotic surgery has less blood loss, lower blood transfusion rate, less operation time, and lower positive margin rate compared to laparoscopic and open method. And although similar positive margin rate to open method, robotic surgery still remains better functional outcomes without any doubt. Next. And therefore, more and more locally advanced or high-risk patients would turn to robotic surgery in order to give it a shot for the chance of en bloc resection. And this phenomenon drives many surgeons crazy under the concern of positive surgical margin, which drags the survival a whole way down shortly after operation. Next. So do we have support for doing this? Next. Gandaglia et al. Published a study in 2017, showed the first study specifically focusing on locally advanced disease treated with robotic approach. A total of 94 patients with clinical stage at least T3 undergoing RARP with extended pelvic lymph node at 3 European centers between 2011 and 15 were retrospectively evaluated. And the surgery was performed using the Da Vinci SI, and perioperative outcome and some parameters are surveyed. And the multivariate Cox regression models assess the predictors of biochemical recurrence. Next. And the median operative time, blood loss, and length of hospital.
The slide.
Next. And the median operative time, blood loss, and length of hospital stay were 230 minutes, 200 cc, and 6 days. And overall, 12 patients experienced complications, and 5, 4, and 3 patients have Clavian 1, 2, 3, and 4 complications. As for pathologic findings, 76%, 36%, and 32% has PT3, 4, PN1, and positive margins. And overall, 19 patients and 21 patients received adjuvant radiotherapy and hormone therapy. At 3-year follow-up, the biochemical recurrence and clinical recurrence-free survival rates were around 63% and 95%. Next. So the data show that RARP represent a well-standardized, safe, and oncologic effective option in patients with locally advanced prostate cancer compared to those with open or laparoscopic surgery. Next. And how was the pattern of recurrence and survival for these high-risk patients operated by traditional open method? Will that be different from robotic series? Next. Let's take a look at the cohort have 2,065 patients with high-risk prostate cancer treated with radical prostatectomy at the 7 tertiary referral centers between 1991 to 2011, reported in 2015 Urology Oncology. The median follow-up was 70 months, and the 5-year biochemical recurrence-free survival rate was around 55%. And the 10-year cancer-specific mortality rate is around 14%. Next. They found that when patients were stratified according to time to biochemical recurrence, patients experience BCR within 36 months from surgery have higher 10-year cancer-specific mortality rates compared with those experiencing later BCR with about 19% versus 4%, and the p-value is very significant. At multivariate analysis, time to BCR represents an independent predictor of cancer-specific mortality as well. So now we know that time to biochemical recurrence represents a predictor of cancer-specific mortality in open prostatectomy. And there should be other detrimental factors accounting for this. Next. The French team reported the result with 100 cases treated by RP for clinical T3 prostate cancer between 1995 to 2005. And only 79 patients of them had T3 disease. And the median follow-up after RP was around 70 months. And the RP was open in 77 and laparoscopic in 27, with no significant demographic difference between. And the 5-year PSA-free survival after surgery was 45%, and the 5-year cancer-specific survival was around 90%. Next. On univariate analysis, Gleason score more than 7, pathological stage T3B, positive lymph node and positive margins were associated with recurrence. And on multivariate analysis, lymph node involvement, margin positive, and higher Gleason score stay significant as predictors for biochemical recurrence. Next. And if there is any difference in robotic surgery, next. Let's take a look back to the study reported by Gandaglia group. They show that higher pathologic stage, higher Gleason score, and the presence of positive surgical margins represent independent predictors of biochemical recurrence at multivariate analysis. Next. So here's the problem coming by. In order to eradicate the residual high-grade tumors, should we start some adjuvant therapy immediately after recovery from surgery? And do we have evidence to support early salvage therapy for the scenario? Next. Although we have strong weapons for salvage treatment, the NCCN guidelines still preferred observation for PSA persistence or PSA recurrence in most patients with negative imaging studies and long PSA doubling time. It is still under debate for early salvage treatment. Next. So to date, there have been 3 landmark studies on the utility of adjuvant radiotherapy in T3 disease, the EORTC, the SWOG, and ARO series. All of them suggesting benefit mainly for biochemical recurrence-free survival only. So take the SWOG 8794, for example. Radiation reduced the percentage of patients with METs from 16% to 7%. And the percentage of patients with clinical local treatment fell from 22% to 8%. However, a statistically significant benefit with regard to METs-free survival and overall survival was not seen in these studies. However, next, I believe that it is very hard to conquer the pressure from the patients when we face the same scenario. So we reviewed our own database retrospectively, and let's have a quick look. We would like to find out the benefit of immediate adjuvant therapy for patients with positive margins. So a total of 461 patients who underwent RARP from December 26 to June 2014 was reviewed. And around 80 patients had positive margins, and the cohort was stratified by immediate adjuvant therapy or not. And the observation group underwent adjuvant RT with or without ADT after biochemical failure. Next. The margin positive rate is around 17%, and the mean age was 65 years old with pre-operative PSA around 20. And around 60% were PT3 disease without any surprise. Next. And higher Gleason score, higher post-op PSA, and more T3B patients were identified in the group with immediate adjuvant therapy. Next. And other parameters are not so different. Next. And we can see the Kaplan-Meier curves showing that no significant difference in terms of biochemical recurrence-free survival, local recurrence-free survival, distant metastasis survival, and overall survival. Next. So it is concluded that not all patients with positive margins should do early adjuvant therapy. But if we could find out the high-risk group for biochemical failure, it might work for them. Next. So we're trying to find out the predictors of our own data. So next. We have another analysis to find out the predictors for biochemical failure in positive margin patients, and the results will soon be presented in the near future. And next. So this is the last slide for a wrap up. Although RALP is performed with acceptable morbidity for prostate cancer with locally advanced disease, the use of post-op adjuvant therapy is influenced by different patient, tumor, and surgical variables. And immediate salvage should not be recommended to all of them. Instead, high risk for biochemical recurrence, for example, high pathologic stage, higher Gleason grading, and the presence of positive surgical margins might deserve more aggressive treatment after more solid data support in the near future. Next. Thank you so much for your attention, and thank you again for this privilege to me.
Yeah, thank you very much, Dr. Yu, for your wonderful talk and a very good review. also presenting a little bit of our data. I think we will keep the discussion and Q&A till the end. Hopefully you can catch up some time, then we can have more discussion. So I will hand over to Professor Ong to introduce the speaker from UM.
Yeah.
Thank you.
Thanks a lot. Thanks, Professor Pang. Thanks, Dr. Yu. I think let's congratulate Changgong Memorial Hospital for the impressive work on the robotic surgery in this advanced prostate cancer disease. Here, we have started a laparoscopic surgery for prostate cancer. Dr. Ahmad will present the topic related to the laparoscopic approach to locally advanced prostate cancer. Dr. Ahmad.
Good afternoon, everyone. Thanks for giving me the opportunity to talk, and I have to thank Changgong Hospital very much for agreeing to collaborate on this webinar series. So, just want to talk briefly about prostate cancer in Malaysia. So, as you can see, total number of cases over 3 years is 1,600, and the stage that we are concerned of, we are talking about locally advanced is stage 3. So, it's about 13.8% in Malaysia. And you can see most of our patients in Malaysia will end up going for radiotherapy and ADT. Okay, so only 20% end up going for prostatectomy. So you heard Prof. Yi's presentation. So, but prostate cancer surgery has actually come a long way from the initial one in 1867 all the way to 2011, where they started the robotic prostatectomy. So surgery for locally advanced cancer, currently for Malaysia, we normally use the EAU guidelines, is stated to offer only to highly selected patients and as part of a multimodal therapy. As Prof. mentioned, some of them selected ones will require some form of adjuvant therapy as well. Okay, we wait for one, but most of these studies are retrospective. So we're waiting for SPCG15, which will be a prospective randomized study to give more information on surgery of locally advanced prostate CA. So you heard just now about the robot. So unfortunately, Malaysia, relatively small country, we don't have that robot. So how do centers such as us manage this kind of patients? So what we do for is laparoscopic surgery. So it's well established in the localized setting. Again, as similar for surgery in general, no strong evidence in locally advanced prostate cancer. There is a retrospective paper, but just mainly a case study. We found laparoscopic surgery to be safe and effective option in Georgia. Okay, as Prof. mentioned, we started our service in 2017. So we use the 3D STOS laparoscope system, and up to date, we have 16 cases operated, and this is the data. Okay, generally our patients are so of these patients, 25% are locally advanced with a prostate size relatively small, and the mean operation length so far is 400, but it's slowly coming down. Okay, our complication data, mean transfusion is about 0.7 packs per patient, and we had 2 Clavien-3 complications. Okay. So just going to show a video of a patient locally advanced patient that we operated recently, 67-year-old, BMI borderline at 25. Basically came because of family history of prostate CA and did the screening and found his ASA is high. So you can see in the left peripheral zone is a lesion on T2, and you can also see enhancement on DWI and the contrast space. Okay, so proceeded for surgery. So most of our patients we will handle preoperatively just for quick identification. We usually use gloves to take the blood specimens out. dissection to the space of edges.
喂？哦，OK。我正在听这个马来西亚的世界会议，他秀这个，这是马来西亚的世界，他在秀他的开刀那个。
就像上次那个。
对对。
You can see this is a locally advanced case, so there's a bit of bleeding in this patient. Thankfully, he didn't require transfusion. It's on the ligation of the DVC. Use a V-lock suture to walk. Now we start dissection of the anterior bladder neck. Using suture intra-abdominal just to hold the catheter up for traction. Once we are cutting the mucosa, we tend to prefer to use scissors rather than energy device. The energy device we use is the Igashual. Ligation of pedicle, we use the Igashual, but some will use Humalog or we use the vascular strip. the catheter in the urethra. To the prostate. We use this method so that I can keep the catheter for traction purpose. This is also located advanced, so it's a bit up to the rectum. So that's why at this part we have to use scissors to dissect off the bigger space. Yeah. So now we start with the version of the brother mucosa. So the advantage of the 3D laparoscope system is that you have depth perception now, so it's a bit easier to do the suturing and anastomosis. So we remove the stent intraoperatively. And we always start with posterior anastomosis at the 3 o'clock position. Get consistent to put perineal pressure to put out the urethra. For this one, we use a relock PO. Final stitch, we insert the catheter and get the balloon completely. Okay, so patient was discharged well after 9 days. It was a bit longer than usual because he developed some post-op ileus. But cystogram, which we routinely do at day 14, was clear, so CBD was removed. He still has some incontinence, but is doing well with Kegel exercise. HB score was a T3B, Wisdom 4+3, and his latest PSA is good at 0.06. This is 2 months post-operation. Okay, thank you very much.
Yeah, thank you very much. Thank you, Dr. Ahmad. So that is the demonstration of laparoscopic radical prostatectomy for case with locally advanced prostate cancer. So we will let Prof. Pang introduce the last talk that everybody from our side is also waiting for on the proton therapy. Proton, please.
Okay, thank you. First of all, thank you, Dr. Ahmad, for showing a nice surgery video clip. It's not a easy task to have a laparoscopic surgery on locally advanced prostate cancer. Yeah, really, congratulations. It's a beautiful surgery. Now we will move on to our last speaker. It's my privilege to introduce our next speaker, Dr. Chan Ding-Li. Dr. Chan is our consultant radio oncologist at our Proton Center. He graduated from Chengkong University Medical School, and he got his training in Chang'an, and now he's in charge of our proton therapy, especially in prostate cancer. I think we know that proton therapy is very advanced in technology to treating prostate cancer, and we are having this treatment like maybe 3 years from now, 3 to 4 years now. So we have accumulated a little bit of experience. So I will let Dr. Chan to present the data and give us a review of proton therapy in prostate cancer. So Dr. Chan, please.
Thank you.
Professor, can you see our slide?
Oh, yes, clear, very clear.
Hello, everyone. I'm Ding-Li Zhang from Department of Radiation Oncology. It is a great honor for me to give this small talk about proton radiotherapy. This small talk will consist of 3 parts. First, I will give a little introduction of proton therapy. Then I will talk about the challenge of proton therapy. Finally, I will talk about the benefit of proton therapy. Since we are already behind the schedule, I will try to shorten this presentation. To talk about proton therapy, we must first know what is proton. An atom is made of outer electron and inner nucleus, and the proton is the basic particle that carries the positive charge in the nucleus. When we remove the electron from hydrogen atom, we can make protons. Then we accelerate protons using cyclotron or synchrotron to produce proton beams to treat the patients. This is proton radiotherapy. Next. X-ray is the most common treatment beam for current radiotherapy. We often use X-ray or photon to treat patients. However, photons don't know how to stop. Therefore, surrounding tissue will inevitably receive a lot of unnecessary irradiation. Unlike X-ray, which penetrates through the body, proton can be stopped. Proton pass through the tissue with lower entrance dose, but release large amounts of its energy when it reaches the desired depth of treatment, which is the break peak, and deposits almost no dose to the normal tissue behind tumor. Since a single break peak is not wide enough to cover the whole tumor, we will add multiple break peaks, smaller break peaks, to make a spread out of break peak, and we use this to treat the entire tumor. Normal tissue beyond the tumor can be spared from radiation dose. Next. This can be very useful in pediatric patients. When a patient is diagnosed with medulloblastoma, the typical radiation therapy field will be craniospinal irradiation, which treats the host brain and spinal canal. When we use photons to treat the patient, although we only need to treat the spinal canal, but photons penetrate through the body, so the normal organ will also be irradiated. But if we treat with protons, it can be stopped at a certain length, so the normal organ behind the tumor will not be irradiated. This will not only reduce the acute toxicity, such as nausea and vomiting. In children, radiation dose to normal tissue may hurt their growth, development, and chances of a second malignancy after treatment. Next. Since the advantage of proton therapy is so obvious, we started to evaluate building proton centers since 1995. Then we really started building the proton center in 2011. After installation, we started clinical trial of 6 patients because we are the first proton center in Taiwan. Then we started really treat patients clinically in the end of 2015. This is the building of our proton therapy center. This is the outer look. This is a 2 floors above the ground and 3 floors underground building. It's a very large building because the proton therapy facility is very large and compact. Next. We use the cyclotron to accelerate proton and use the beam transport system to transport the beams to different treatment rooms. Every treatment room is equipped with the gantry, which is about 140 tons in weight and about 10 meters in diameter. So every gantry is very large and heavy. And to perform accurate setup for treatment, each room is equipped with advanced imaging system, image guidance, and a robotic couch with 6 degrees of freedom to adjust patient's positioning and angle to produce better accuracy of positioning. Next. We've treated patients since the end of 2015, about almost 5 years of treatment. We've treated 2,790 patients. Most of it is HCC, liver cancer. It's about a quarter of our patients. Then head and neck cancer, about 20%. Lung cancer, brain cancer, and breast cancer, about 10%. How many patients did we treat, prostate cancer patients? Well, this is only 26 patients we treat with prostate cancer, less than 1%. Why is this number so small? Next. This is partly because that in 2012, JAMA published a paper comparing proton therapy and other X-ray therapy to treat prostate cancer, which concludes that IMRT compared with proton therapy was associated with less gastrointestinal morbidity. Well, this probably is the doomsday of proton therapy for prostate cancer, because after this paper published, many patients will not, because proton therapy is very expensive and with no advantage, even more gastrointestinal morbidity, patients will not prefer proton therapy for prostate cancer. Next. Not only this paper showed that proton therapy might induce GI toxicity, other studies show that proton therapy may increase more GI toxicity. And about GU or sexual toxicity, it's about no difference to IMRT or a little bit decrease. But most studies show that no difference can be shown between prostate cancer treatment with IMRT or proton therapy. So what is the problem with proton therapy? Well, there are some challenges of proton therapy. Since this is a relatively new technique, there is learning curve to make the best use of it. There might be some reason that proton therapy did not reach our expectation. First, proton therapy is very sensitive to path length changes, so immobilization and quality assurance is very important. The prostate is not well fixed in the pelvis. The position of prostate changes with the volume of bladder and rectum. Not only the prostate moves, sometimes the whole body contour changes during the course of radiotherapy. This is the CT scans of a same patient taken at different times during the treatment course. We can see the difference is very obvious. This all affects on the proton dose distribution. Next. Because the proton beam is very sensitive to path length changes, when we use proton beams to treat the patient, every little detail might diminish its dose distribution benefit. When the patient was treated after several times, this patient became more relaxed, so the femoral head angle is also changed. So the path length is changed, and the proton distribution is changed. So maybe the dose distribution benefit shown in the planning system will not be demonstrated in the real treatment world. Next. Second, the comparison of photon and proton therapy is not really fair. Those studies comparing the most advanced proton therapy with not so mature proton therapy. when we treat prostate cancer patients with X-ray, we now routinely use the lowest technique, which is rapid arc or Vmat, volumetric modulated arc therapy. This is a more advanced form of IMRT. It not only treats the prostate from several different angles, actually it treats the prostate from all directions. With all directions it uses, Vmat can be more conformal than the more simple form of proton beam treatment. Next. So this is the dose distribution of Vmat versus proton therapy. We can see that proton therapy really decreased the integral dose to the rest of the body, but about the conformality, Vmat seems better, especially about the high dose region to the rectum. We can see that Vmat can reduce the high dose to the rectum, and proton therapy, the dose distribution is more flat, so the anterior portion of the rectum will be irradiated. Next. Several dose comparison studies have been made, and we can see that comparing photon and proton therapy, the mean rectum dose and mean bladder dose can be reduced because the posterior part of the bladder, posterior part of the rectum and the anterior part or upper part of the bladder will not be irradiated. So the mean dose to bladder and rectum will be reduced by proton therapy. However, this dose might not cause any significance because this dose is not related to toxicity. The high dose region is what is important for the toxicity. Next. This is the high dose region comparison. Rectum V70 is the volume of rectum receiving more than 70 gray, and same is about bladder V70. We can see that the bladder V70 is almost the same with photon and proton therapy. So there it is understandable that proton therapy cannot reduce bladder toxicity. And about rectal V70, we can see that the right column is proton therapy, the left column is photon therapy. We can see that proton therapy can be even higher. More rectum will receive higher dose of, more volume of rectum will receive higher dose of radiation in proton therapy. This is more obvious when the treatment volume is concave shaped. Although IMRT and Vmat might increase the low or intermediate dose throughout the pelvis, these doses cause almost no toxicity. Rectal toxicity came from the high dose irradiation to the rectum. As this picture showed, conventional or passive scatter proton therapy may not be better than IMRT or Vmat. We can see that half of the rectum is getting 74 gray. This will definitely cause rectal toxicity. But there is also advances in proton therapy. Next, as we use photon therapy to treat prostate cancer, we use IMRT or Vmat, which is more advanced form. Next. But as the time goes, every technology improves. So we use 3D CRT X-ray from the 1980, then improved to IMRT. Then we advanced to Vmat in about 20,000. And then we moved to passive protons in 2005. Then there is Impt. Impt is the intensity modulated proton therapy. This is the proton form of IMRT. This can be more conformal. Next, Impt or pencil beam scanning allow concave shaped dose distribution. So if we treat the prostate and seminal vesicle, we can really spare the high dose region to the rectum. Next, with modern IMPT technique, proton therapy can be more conformal than Vmat, which really reduces the dose to the rectum, as this dose volume histogram showed. Next. So if we compare various forms of radiotherapy of photon and proton, we can see that with the older technique, 2D X-ray, then we move to 3D X-ray, then move to IMRT, we can see that more and more conformal than the dose distribution. However, it is at the cost of normal tissue exposure, because with photons, we use different angles to treat the target, and to spare normal tissue, the cost is to spread out the intermediate and low dose to the normal tissue. But with proton therapy, the normal tissue exposure is less. And with IMPT, this can be more conformal than conventional protons. The value of IMPT can be shown in this graph. A comparison of passively scattered proton beams to IMPT is shown in this picture. The urinary and rectal toxicity can be reduced, and this is the IMPT result is better than the conventional proton therapy. Next. So if we compare more recent IMRT and proton therapy results in the hand of more experienced proton therapy center, we can see that the PSA control is better than the IMRT result. The low-risk group can reach almost 99% PSA control, and the intermediate risk is about 94 or 95%. And the rectal and urinary toxicity is decreased with less than 1% of rectal toxicity and about 3% or 0% of rectal of grade 3 or higher rectal toxicity. And proton therapy can reduce the integral dose to the normal tissue surrounding the pelvis. This is the difference between IMRT and protons. If we subtract IMRT dose from proton therapy, we can see that the difference, which showed in the right column, right picture, this is the difference, which is about 25 gray. This excess 25 gray irradiated through the body might not cause toxicity, but how much is 25 gray of unnecessary radiation? This is about taking 2,500 pelvic CT or taking 20,000 pelvic X-ray. So this might induce secondary malignancies. Next. Since the patient who has prostate cancer can live for a long time, we observed that a lot of patients have another cancer after his prostate cancer was controlled or cured. Radiation is a definite carcinogen. So if we reduce the radiation delivered to the body, the risk of secondary malignancy can also be reduced significantly. This is the benefit of proton therapy. Next. So, theoretically, the best RT method can be proton therapy. It had a better physical property and least dose to normal tissue and less adverse events. With the use of IMPT, the dose can be more conformal. Even the rectal toxicity and GU toxicity can be reduced, and less risk of secondary malignancy can be spared, because using protons can irradiate less integral dose to the body. But in reality, proton therapy is very expensive, especially in Taiwan, because the photon therapy is covered by insurance. It's almost free, but a proton therapy, we have to self-pay. And quality and precision are extremely important because the proton therapy is very sensitive to the path length changes. No survival benefit is shown in proton therapy because if the same dose is radiated, the same disease control can be expected. So with no higher dose, there's no survival benefit, but we can see that proton therapy might reduce rectal or bladder toxicity or the secondary malignancies in the future. Thank you.
Okay, thank you very much, Dr. Chan, for your wonderful talk and give us a very good overview of proton therapy in prostate cancer treatment. It looks like we still need improvement in the proton setting so that we can add more precise treatment and with less toxicity. But we do learn a lot from you today. I think I will hand over to Professor Ong because we are running out of time. So what do you think? Should we have a question or Q&A time?
No, I think it's already 1:30. We like to thank the audience from Taiwan, from Malaysia, I think from neighboring country, there are urologists who tune in. And also we have patients who actually tune in, our own patient who survivor who tune in as well. I think that there are some questions in the FB Live, but I think it's already 1:30. I think that one, the question we can answer that later by the respective speaker. We will put the answer in the FB Live link later on. I think we should end the session today.
Yeah, I think once we get experience and good response from the audience, we can continue our webinar in the future.
Yeah.
We can have more topic together. Yeah, thank you.
Okay. All right. Thank you, everybody. Thank you.
Thank you. Bye.
Yeah. Bye-bye.